Chapter 28 here, musculoskeletal trauma. Alright, so the system, bones is the framework of it all. You have joints for bending and muscles for movement. Those are your three components. Also within that you have cartilage, which is for flexibility. Ligaments connect bone to bone, and tendons connect muscle to bone. Know the difference between those two, ligaments and tendons. So the bones is formed of dense connective tissues. Now, pediatric note, just remember the bones are not as formed as an adult. They're a little bit more flexible. They're vascular and susceptible to bleeding on injury, especially your large bones such as the femur is covered by periosteum. Little diagram of the bones in the skeletal system, and this is in your book. Definitely know the bones of the arms and the legs. Those are the main ones in your pelvis there. So bones are a classification of shape: irregular, long, short, flat. Here you have the irregular bones, which are your vertebrae. Flat, your ribs or your scapula in the back there. Long bone, humerus, your femur. And your short bones are your tarsals. Self-healing nature of bones. Break causes soft tissue swelling and a blood clot in the area of the fracture. The interruption of the blood supply causes the cells to die at injury site. Cells further from the fracture rapidly divide, forming tissue that heals the fracture and develops into new bone. All this happens automatically. Kinds of muscles: skeletal, voluntary, smooth, involuntary, and then you have cardiac, myocardial. Cartilage helps form flexible structures of the body. Tendons allow for the power of movement across joints. Muscle to bone, muscle, tendon, bone. Ligaments support joints by attaching bone ends to allow for stable range of motion. Bone, ligament, bone. Just a diagram of the types of muscle there. Here's diagram showing your muscle, bone, the tendon, ligaments. This is in the leg. Got your femur up there. General guidelines for emergency care. So the different mechanisms of injury: you have direct force, indirect force, and then twisting, rotational. A fracture is any break in a bone, whether it's open or closed. Comminuted, broken in several places, not just one place. A green stick is incomplete, hasn't gone all the way through the bone. Think of like a crack in the windshield, how it doesn't go all the way through at times. That would be like a green stick. Angulated is a bent angle. Now here's a pretty good picture. Injury to the ankle there. It appears just to be dislocated. That can be very it takes your mind away from everything else. Okay, don't focus so much on something like that. Make sure there's no life-threatening injuries. Okay, here at the bottom it does say a closed fracture. Yeah, I'm still gonna say that's looks more dislocated than anything. But don't let it take your mind away from everything else going on with the patient. So dislocation basically comes apart at the joint. A sprain, stretching, or tearing of ligaments. I'm sure you've all sprained your ankle at some point or another. A strain is overstretching or overexertion of the muscles. Not all injuries can be confirmed as a fracture pre-hospital setting. Some of them can be very obvious, some of them are not. I've had femur fractures that I never even knew it was fractured until after they did x-rays at the hospital. There was just no way for me to tell. Then I've had people that had multiple tib-fib fractures in their lower leg, and their lower leg was like rubber. It was all over the place. I don't know if you guys are Harry Potter fans, but when Harry breaks his arm there and they try to heal it with the spell, how how it was flipping all around. That's how this dude's leg was. So, splinting an extremity with a suspected fracture helps prevent blood loss and from the blood tissues. Keeps everything in line and keeps it from bleeding as much. So, rapidly identify and treat life-threatening conditions as always. Your ABCs. Be alert for injuries besides the grotesque wound. Some of these can be very distracting, okay? Make sure you're alert for everything else going on with the patient. Cut or remove patient's clothing to completely examine according to the environment and severity of the situation. It's not always going to be that you're going to cut a patient's clothes off, but if it warrants it, you need to do so. In an ambulance, typically it's not going to be right there on scene. It does happen at times, but it should be in an ambulance. Compartment syndrome. Severe swelling in the extremity as a result of a fracture. All that bleeding and swelling, it causes a lot of damage. So the progression, the fracture or the crush injury causes bleeding and swelling, right? The pressure and swelling becomes so great the body can no longer perfuse the tissues against the pressure, okay? So you're not perfusing, which is what? A form of shock, right? So cellular damage occurs, causing additional swelling. All that water and everything is being pushed out. Blood flow to the area is lost. Limb may also be lost if the pressure is not relieved. So patient assessment, you're looking for pain and tenderness, deformities or angulation. You're looking for that crepitus, that crackling or whatever, with the bone against bone. Swelling and bruising, any exposed bone ends, be pretty obvious. Joints locked into a position, nerve blood vessel compromise, compartment syndrome. That's going to be kind of difficult to diagnose in the field, but you want to pay attention for that. So you're looking for the 6 P's: pain or tenderness, pallor, pale skin, right? Oh, good lord, I'm not even going to try it, but it's going to feel like pins and needles, right? You ever had like your arm fall asleep? It's going to be that feeling, okay? And that's from the lack of blood flow. Pulses are diminished or absent. You're always looking for the pulse distal to the injury. Paralysis and pressure. So do my patient's musculoskeletal injuries add up to a serious multiple trauma? You're going to have a high level of suspicion of that depending on the mechanism of injury and how they're presenting to you. Does my patient have circulation, sensation, and motor function? PMS, right? Distal to the suspected fracture or dislocation. You need to always check for that. So for care for these types of patients, standard. It's the same across the board for traumas. You're going to take your standard precautions. You're going to perform your primary assessment, your ABCs. During the secondary assessment, apply a cervical collar if you suspect spine injury. Splint any suspected extremity fractures after treating life-threatening conditions. Cover up wounds with sterile dressings. So splinting. It minimizes movement of disrupted joints and broken bone ends, prevents further injury, right? Especially during fractures, you don't know how bad the fracture is. You can have sharp edges of the bone that can damage a lot of the soft tissues, the nerves, arteries, veins, and muscles inside there. You want to prevent that movement and prevent that from happening. It will actually decrease pain for the patient, especially if you can get everything in line. Minimizes blood loss and can prevent a closed fracture from becoming an open fracture. Realignment of a deformed extremity. Take extreme caution when doing this. It assists in restoring effective circulation to the extremity and to fit it into a splint. If it's not realigned, splint may be ineffective, causing increased pain and possible further injury. Again, this needs to be done with extreme caution if your protocols allow it. Okay, and this is not something you're going to waste time on scene doing. If you can do it, great. If not, get your ass to a hospital. Here's the trying to realign the extremity. So if not realigned, increased chance of nerves, arteries, and veins being compromised. Increased pain is only momentary. So the guidelines for it, one EMT grasps the distal extremity while partner places one hand above and below injury site. Partner supports first EMT who creates gentle manual traction in direction of the long axis of the extremity. There's no resistance. Maintain gentle traction until the extremity is properly aligned and splinted. Again, you're going to do this with extreme caution. Even the attempt of doing so can cause further injury. You need to weigh the risk and benefits of it prior to doing so. So, effective splinting may require some ingenuity. I'm going to tell you, rarely is an injury splinted the same way as another one. You have your certain tools that you have for splinting, and you make it up along the way. There's a good way of doing it. There's a bad way of doing it. Really, as long as it's splinted, I don't care how you get to the final product. But you'll see as you're out there and we do this hands-on. You may come up with a way different than how I do it, and there's not a set way. So you have rigid splints, formable splints like your SAM splint, and then you have your traction splint. So always care for life-threatening problems first, right? As we say for everything. Expose the injury site. You may need to cut away clothing. You want to assess your distal circulation, sensation, and motor. PMS, pulse, sensation, and motor. I guess they call it CESM, so I was not confused with PMS. But anyways, align long bone injuries to anatomical position, if able to do so. Do not push any protruding bones back into place. Mobilize both injury site and adjacent joints, the joint above and below the injury site. Choose splinting method based on severity of condition and priority decision. Apply splint before moving patient to a stretcher or other location if possible. At times you will splint before you move them. A lot of times it's in the rig before you get going. Pad any voids. And this is actually important, using blankets, pillows, whatever you may have readily available in the ambulance. When you splint a patient, a lot of times there's going to be voids between them, the stretcher, them, the backboard, whatever. By padding those voids, you're preventing further movement, preventing further injury. Hazards of splinting a patient to death. Okay, and this is splinting before life-threatening conditions are addressed. You would think that's a pretty simple concept, treat life-threatening conditions. A lot of the times, as I said before, these injuries can be very grotesque. They're very distracting. You show up, you got a femur sticking out this guy's thigh and blood everywhere. I mean, that's what you're going to focus on, and you're missing the fact that he doesn't have an open airway. Not ensuring the ABCs. You're not paying attention. You're trying to get this splinted because that's what your focus is on. It can be too tight. Compresses the soft tissues. As long as you don't have a long transport, typically it's not going to be that big of an issue. Too loose allows for too much movement and splinting in a deformed position. As always, take standard precautions, gloves at minimum. If possible, expose the area to be splinted so you can fully check for injuries. Manually stabilize the injury site prior to splint. Alright, so assess your PMS, circulation, sensation, motor. Realign injury if deformed if possible, or if distal extremity is cyanotic or pulseless. This is the times that I will actually try to realign an injury. If I don't have a pulse, they're blue, the extremity is cold from lack of blood flow, I will try to realign. So they're checking for sensation by pinching the patient's skin there. Measure or adjust the splint. Move it into position. Apply and secure splint to immobilize injury site and the adjacent joints. Remember, you're going to splint the joint above and below. Reassess the PMS distal to the injury. So there they have a SAM splint. Great things. I love those. That's actually pretty ingenious right there. You know, we will have to try this in with the hands-on. If you notice between the bicep and the forearm there, they took another piece of the SAM splint and made like an angle brace, an angle bracket right there. I've never seen that done, and it's something I would like to try in person. So we'll see how that goes. They're reassessing the pulse right there. Alright, traction splints. Counteracts the muscle spasm and greatly reduces pain. And here's your types are bipolar, unipolar. Amount of traction applied should be roughly 10% of patient's body weight, not exceeding 15 pounds. In an emergency situation, you're not going to remember that number. Be honest, in emergency, all you're going to do is keep going until they don't feel pain. Yeah, that's the best I can tell you. We'll get these out and we'll play with the different types. But that number is something you're definitely going to need to know for a test. Take standard precautions. Rule number 1, always, right? Expose the area if possible. Manually stabilize the leg and apply manual traction. You guys seeing a pattern here. Assess the PMS distal to the injury. I apologize for always saying PMS. It's old school way instead of CSM. PMS, pulse, motor, and sensation. It's what I'm used to. So even when I see CSM, I will still say PMS. Adjust the splint to the proper length and position it at or under the injured leg. Apply the proximal securing device. Can be a strap, depending on what type of traction splint you're using. Apply the distal securing device, usually around the ankle. Apply mechanical traction. Position and secure support straps. Then you're going to reevaluate proximal and distal securing devices, reassess PMS distal to the injury, secure the patient's torso and the traction splint to a long spine board to immobilize the hip and to prevent further movement. And we're going to cover all of this hands-on. Alright, shoulder girdle injuries. Pain in the shoulder, dropped shoulder, typically with a fractured clavicle, severe blow to back over scapula. So patient care, ABCs, life-threatening, right? Then you're going to assess the PMS. Use a sling or a swath. If evidence of anterior dislocation of head of humerus, place pillow between patient's arm and chest. If it looks like the shoulder is dislocated, put the pillow in between there, it may help. Do not attempt to straighten or reduce. Reassess PMS. Pelvic injuries, pain in pelvis, hip, groin, back, pain when pressure applied to the iliac crest. Can't lift their legs when lying on back. Lateral rotation of foot. Unexplained pressure in the bladder, bleeding from urethra, rectum, or vaginal opening. You can see that depending on what part of the pelvis is injured. Main thing, lose them as little as possible. Okay? They're in a shit ton of pain. Pelvic injuries, they bleed a lot. Okay? Quickly go into shock, become hypotensive. Determine the pulse motor sensation distal to the injury site. Check down there, top of the foot, make sure they can feel everything. Straighten lower limbs into anatomical position. Stabilize the lower limbs and assume spinal injuries if they have pelvic injuries. Reassess. PMS. Care for shock. O2 if needed and titrate. Transport patient as soon as possible. Monitor vital signs. Now they do have things such as pelvic slings now, which are great to use. They do help. It's one of those commercial devices. Yeah, there's different kinds out there, but if you do have them, check with the service that you're working with on how to use those properly. I will bring one to some hands-on training. So they are applied to patients who have a pelvic deformity or instability, whether or not signs of shock are present. I have not seen one of those before. But yeah, ours is a little bit different that I'll be bringing. Pelvic wrap. Yeah, you lay it flat, you fold it. It works, I guess. The thing is, you still have to move these patients in order to use these things. But once you have it on there, it should take their pain away pretty good. Hip dislocation. You'll see a lot of these with the elderly, even with ground level falls, okay? Anterior hip dislocation, posterior hip dislocation. So you're going to see a rotation of the leg inward and knee is bent. Foot may hang loose and unable to flex or lift the toes, lack of sensation in the limb. Care as always. Assess for PMS. Move patient onto long spine board, that's the best for moving these, or even a scoop stretcher. Mobilize the limb with pillows and blankets. Secure patient to spine board. Reassess PMS, care for shock, transport. Pretty easy. It's pretty basic all the way across in the traumas on how you care for them. Geriatric note, old people, right? Direct force and twisting forces can cause a hip fracture very easily with these patients. Simple falls, you're going to see it all the time. MVCs are more susceptible to that. They're just because of their bones, the breakdown of everything, they're more prone to injury. And brittle bones, weak. They have other diseases affecting it, osteoporosis, things like that. So the pain is localized. They're going to have pain in their hip. Okay, they're going to have pain right there, or possibly at the top of the femur there, depending on what's affected. Surrounding tissues at times are discolored. Honestly, it's not all the time. It may be a little red, depending on how bad the fracture is or dislocated. Can be a little bit purplish. Swelling may be evident, may not be. Unable to move limbs while on their back. Unable to stand. You're going to have that foot turns outward. Injured limb appears shorter. Okay, so when they're on the stretcher, the injured limb will appear shorter. We call it shortening of the leg. Okay, so you get down and you look at the heels of their feet. You want their legs stretched out fully, okay? The injured limb, the heel of the foot will be shorter. Yeah, like their entire leg is shorter. That's caused from that fracture, or it's caused from that dislocation. You'll see that almost every time. So patient care, place folded blanket between patient's legs and bind legs together with wide straps. Use then splints to push the cravats or straps under patient at natural voids and readjust so they will pass across the chest, the abdomen just below the belt, below the crotch, above and below the knee, and at the ankle. As you see there, how they're strapping them in. Now, the cots nowadays, it's not like that. You don't have all of that, but yeah. Typically, all you're going to do is you're going to place a pillow between their legs and you're going to strap them down normally. So they're going to have intense pain with the femoral shaft fracture. Your femur can be open. A lot of times it will. And your limb may be shortened. That you're going to see that again down there at the feet. Control bleeding. Okay, manage for shock, provide O2, assess your PMS, traction splint. Anytime you have a long bone fracture, you want to use traction splint as long as, everything else meets the criteria. You can't have any injuries below the middle joint there, no injuries to the knee, etc. PEDS. When traction splinting thigh injuries in children, be sure to use appropriately sized splints. Some of the splints out there are adjustable, makes it great, for the different sizes of the patients. Infants and children with fractured femurs often have injuries in internal organs. Okay, you think about infants and children, their bones are more flexible, they don't break their bones as easily. Okay, so if they have enough force to fracture their femur, there's probably more injuries going on internally. Knee injuries, pain and tenderness, swelling, deformity with swelling. Again, same treatment. You're going to check your PMS. You're going to immobilize and reassess. Tib-fib fractures, again, pain, tenderness, swelling, possible deformity. They can be open, they can be closed. Apply air inflated splint if you have them. They work great really for any fracture if you're equipped with them. Immobilize fracture using 2 rigid board splints. There's a lot of different options. You just want to prevent movement. Whatever you have available, whatever you want to use. Apply a single splint with ankle hitch. Ankle foot injury. Here we go again. Pain, swelling, possible deformity. Patient care. Again, assess PMS, stabilize the limb. Place Kravitz under the ankle, lower limb onto pillow, tie pillow around ankle. You're splinting. You're splinting, you're preventing movement. Then afterwards, you're going to check PMS again. All right. So elevate with second pillow or blanket. Reassess the PMS. Care for shock if needed. Apply ice pack as needed. Yeah, with ankle injuries, foot injuries, I will give them a cold pack, not directly on the skin. Forearm, wrist, hand injuries. If you notice here, what's the main thing? Deformity and tenderness. Deformity and pain. Okay, it's all the same. Splinting forearm, wrist, and hand injuries. Fingers. You're just going to splint them to the finger next to them, unless you have like some popsicle sticks that you guys carry in your ambulance, but that's the easiest way to do, splint it to an uninjured. There you have your little popsicle stick deal, tongue depressors, whatever you want to call them, but yeah, you can split it that way as well. Patients who suffer fractures can be in extreme pain. Pain can cause anxiety and elevated pulse rates. How could you differentiate between a patient with a rapid pulse and anxiety from pain versus a patient with a rapid pulse and anxiety from shock? What is shock? You're not perfusing, right? Okay, so you're going to look for signs of that. And they're going to be hypotensive. That blood pressure is going to be down, right? Very simple. Traumas, as long as you can make sure that you're not distracted by a grotesque injury, bones sticking out of the skin, whatever, as long as you can remain calm and make sure you follow the steps, they're super simple, okay? Doesn't matter if somebody just twisted their ankle or you have, a horrible 1050 with blood everywhere and multiple fractures. The steps you're going to take are the same. ABCs. You're going to treat life-threatening injuries. You're going to take care for manual stabilization of C-spine. If you suspect spinal injuries, right? You're going to splint. You're going to check for the PMS prior to and after splinting, right? You're going to take care of the wounds. It's very simple, very straightforward.